Hello, my name is Pichelstorfer from the University of Vienna. Today I will be talking about the role of data in global health diplomacy, using a case study which I conducted with my colleague Katharina Paul and which investigates WHO practices of collecting data on immunization. The ongoing COVID-19 pandemic has shown that data and global health are inextricably linked. It has made the often invisible infrastructures visible that are used to collect, share, and analyze health data on a global scale. We all became familiar with analysis and graphical representations of clinical, epidemiological, and demographic data, which were used to understand the progression of the disease or the effectiveness of responses, such as vaccinations. Today, global health is saturated with metrics. In the area of vaccination that I will be focusing on in this lecture, data is not only used to measure and understand the state of health around the world, but also for policy development, funding decisions, and research. Underlying this focus on the generation and use of data in global health is a particular vision that good data saves lives. So better data is often equated with better health, and many global health policies now include the target of improving data quality or setting up new data infrastructures for ever more data collection. Aside of putting the spotlight on the role of data, the current pandemic has also made clear that effective responses to global health threats, which transcend national borders, require more diplomatic coordination at the global level. Literature on global health diplomacy has so far largely focused on public health emergencies and the securitization of health. More mundane diplomatic practices happening in the background and over a longer period of time have gone unnoticed in these discussions on health diplomacy. Specifically, those practices that concern data collection, data sharing, or analysis. In this lecture, I argue that data practices and the infrastructure for collecting, sharing, and analyzing data are important sides of global health diplomacy. Global health diplomacy is an emerging field, both for researchers as well as for practitioners. A key feature is that it requires both technical and foreign policy skills and involves not only diplomats but a variety of experts. Global health diplomacy describes the practices by which governments and non-state actors attempt to coordinate and orchestrate global policy solutions to improve global health. Many different practices are currently denoted as health diplomacy in literature and by practitioners. A useful categorization and distinction was drawn by Rebecca Katz and colleagues. They argued that for one, there's core diplomacy, which refers to bilateral and multilateral negotiations to resolve conflicts or implement agreements, usually involving official representatives of nation states or international organizations. Examples would be the revisions of the International Health Regulations in 2005. Here, the negotiations focus not only on the responsibilities of the states to report outbreaks, but also on science and data. In particular, the sharing of information. So this already points to the increasing importance of data in global health. Another category is called multi-stakeholder diplomacy, and does justice to the fact that not only state actors, but also government agencies, NGOs, philanthropies, multinational organizations work together in global health diplomacy. It refers to the bilateral or multilateral partnerships or global initiatives such as Gavi, the Vaccine Alliance, which is a public-private partnership and was founded by the Bill and Melinda Gates Foundation, the WHO, UNICEF, and the World Bank. And finally, informal diplomacy refers to interactions between public health actors from inter- and transnational organizations and their counterparts in the field, including host country officials, representatives of multilateral and non-governmental organizations, private enterprises, and the public. Actors working in this field of diplomacy are usually technical experts in public health, often governed by their own programmatic requirements of their jobs, and they interact usually routinely with one another. Furthermore, they are often unaware of their representative function. Examples would be experts who negotiate standards or procedures, or who provide assistance or guidance to other states, as well as researchers engaged in international research collaborations. With my case study, I want to draw attention to this third dimension of health diplomacy, and in particular shed light on the use of data to shape, enable, and facilitate diplomatic activities of the WHO. As became clear in the past year, infectious diseases are transnational matters, yet the deployment of the related policies remains largely within the remit of national borders. Immunization is a case in point. Funding and implementation are national, sometimes even subnational matters. However, historical analysis have shown that the development and administrations of many vaccines are tied to diplomatic activities. The WHO has early been engaged in and has been a side of these diplomatic activities and took a leading role in global vaccination governance. Their leading role in implementing global immunization policies to guide national efforts and negotiate agreement has, however, been weakened since the 1990s, given the fact that other actors, in particular private actors such as the Bill and Melinda Gates Foundation, got engaged in global health. With our case study, we want to show that the WHO nonetheless upholds and expands its political authority in member states and on a global scale, using data practices, such as the composition and use of vaccination coverage rates. The aim to provide expertise on health metrics, such as coverage rates, has characterized the activities of the WHO since the 1970s. The need for metrics and health data was fueled by global efforts to vaccinate children around the world, which took place in the second half of the 20th century. With the introduction of the expanded program on immunization by the WHO in 1974, a program which aimed at implementing immunization programs around the world in the member states, immunization goals to be achieved by the countries were translated into targets that could be measured and evaluated and required an increasing amount of data to be collected. From this point onwards, countries started reporting immunization data to WHO, which was used to gain an overview of vaccination coverage rates across countries and regions. What you see here is a map which visualizes the share of 1-year-olds being vaccinated against measles in 1980. And the gray spots here on this map indicate that no data is available for large parts of the world. This changed substantially in the past decades. On the map here, to the left, you can see the share of 1-year-olds being vaccinated against measles again in the year of 2019. And you see that data is now available for almost all countries and regions. The data collected on immunization in the past decades, and in particular metrics such as coverage rates, informed subsequent policy developments by shaping the very understanding of the issue at stake. Particularly the late 1990s saw an increasing push towards greater immunization policy coordination at the level of the WHO, and these initiatives rested on the problematization of coverage rates at the time. This had two important effects. First, the collection of data on vaccination coverage helped to shed light on global inequities, and through doing so, also actively defined immunization as a policy problem that required global solutions. Coverage rates thus co-produced the needs for monitoring and managing immunity through global health actors such as the WHO. In other words, immunization data helped to create knowledge about immunization on a global scale, and by that also helped to promote the authority of the WHO as the responsible organization for global immunization. Second, immunization data also informed formal or core health diplomatic negotiations that led to international agreements, such as the Global Vaccine Action Plan, which was endorsed by WHO member states at the World Health Assembly in 2012. Data can thus play a role for diplomacy by informing diplomatic activities which aim to develop global agreements. Our case also shows that data practices are important sites for the WHO to steer member states towards achieving the immunization goal it has set, in addition to this core diplomatic function. So how do these more mundane diplomatic practices that rest upon data infrastructures look like, and who is involved in these practices? To answer this question, we need to take a closer look at how immunization data is actually collected, shared, and used. The calculation of coverage rates that leads to those maps that I've presented beforehand, and the collection of immunization data involves a complex process and is usually done by public health experts at different sites. Moreover, the ways by which data is collected vary substantially across countries. Some countries started to collect data at the site of administering the vaccine, for instance, a clinic, and then sent the data to a district or national public health office, using Excel sheets or paper, or they enter the information into a centralized database. Data is collected at the national level before it makes its way to the WHO. Some countries, however, use coverage surveys instead to learn more about the share of the population being vaccinated against a specific disease. And again, the survey methods to do so might differ from one country to the next. Given these huge differences in how data collection is taking place and the fact that sometimes different coverage rates are being published for one and the same country, as well as the fact that disease outbreaks still happen in countries which report high vaccination rates, the accuracy of immunization data was increasingly questioned. Public health scientists who analyze the data for research purposes, but also expert groups advising government bodies and the WHO called for better data infrastructures and more harmonization when it comes to immunization data for some time now. And they still, in fact, call for more harmonization and better data quality. The way how the WHO did address the problem, while not having actually the mandate to prescribe how countries collect and use the data or organize their public health system, was by setting up a new data infrastructure to collect information in 1998. This implementation of the Joint Reporting Form, or GRF, was a response to a kind of double problem. On the one hand, the scientific problem of accuracy of the data, and on the other hand, of the political problem of lacking the mandate to intervene in member states. The Joint Reporting Form was published and developed by public health experts of the WHO together with UNICEF. All member states agreed to send their coverage data using this form, and the high degree of compliance with the reporting guidelines in the past years demonstrates that the GRF became the central infrastructure for gathering and calculating coverage rates globally. Initially, the GRF took the form of an Excel sheet which needed to be filled out by member states and sent back to the WHO once a year. This sheet is actually currently being revised with the aim of setting up a digital information system for collection of immunization data. Yet the GRF, as I said, became quite successful because it was flexible enough to allow for local variety, yet standardized enough or good enough for the job of creating objective numbers to be trusted. It sets the standard as to what data shall be collected, but not how that data shall be collected. So member states can still decide whether they would like to collect the data by means of coverage surveys or centralized information systems or any other systems they have in place. It is this sensitivity to local context and its function as a mediating between the global standards and the local practices, which makes it such a successful diplomatic tool. This data infrastructure does not only produce data that then feeds into diplomatic negotiations, such as the development of the Global Vaccine Action Plan. It is the very practices of collecting the data that are used also as an opportunity for diplomacy by WHO experts, as our case study shows. The implementation of this joint reporting form did not only include the making of an Excel spreadsheet to collect the data, but involved the setup of an infrastructure around that form, which included regular bilateral interaction on the data collected, including processes of data validation between WHO and UNICEF offices and the member state countries. This infrastructure is part of the diplomatic role that WHO plays, as one of our informants told us. It allows the WHO experts to engage with and start a dialogue of identifying areas of improvement in member states. In other words, it enables diplomatic relations between the WHO and individual countries. How do these diplomatic practices look like, which aim at getting more reliable data on the side of the WHO? Once countries have reported their data to WHO using the GRF, WHO experts, who often have a professional background in public health, medicine, or statistics, analyze the data provided by member states and send their analysis and results back to the countries. In this process, they often ask for additional information on local conditions in member states to better understand the data reported. For instance, why coverage for a certain vaccination suddenly dropped, or why the target population increased substantially from one year to the next. This process of getting additional information from member states, which could not be collected with the GRF, is called expert consultation. In some cases, WHO representatives also travel to member states, spend a couple of days there, learn more about the local data infrastructures and immunization program, and provide advice on how to present and analyze the data. Those technical experts at the WHO usually engage with their counterparts in member states, so the other side of the diplomatic relationship, who are also often public health experts responsible for either implementing immunization policies or drafting immunization policies, or data scientists at the ministries of health or specialized government agencies responsible for data collections. Sometimes these interactions are supported by so-called WHO country offices, which exist in some but not all member states. But often, these interactions between WHO and member states depend upon long-term relationships established between the public health experts on both sides, as our interview partners told us. WHO experts and their counterparts in the field act as health diplomats in this case. And when the WHO experts push for more accuracy and better data quality, we find they do so with a political sensitivity that resembles those of diplomats. They are quite aware of the fact that a change in technical standards or more accuracy in data collection might have important political implications for member states. For instance, when they lose their status as measles-free, or when their coverage rates drop substantially and thus might affect the funding they receive from global health donors. In addition to setting up the joint reporting form as central infrastructure, the WHO and UNICEF implemented new methods to analyze the data, as well as rate the quality of the data provided by the countries in the past years. The result of these calculations and analysis are published annually for each country. The graph you see here, for instance, visualizes the estimation of coverage achieved among children aged 4 years in Austria in 2018, according to the WHO. It also includes the so-called grade of confidence, which you can see here, and which is a measure of the empirical evidence which supports the coverage rate estimate. In this case, Austria received only 1 or 2 dots out of 3 possible dots. So the grade of confidence is measured in dots, thus making visible that the empirical data is not as good as it could be. So the highest measure to achieve would be 3 dots. WHO representatives foreground that these estimation methodologies and the grade of confidence which are published are merely technical in nature, yet we argue that there is a considerable power in such exchanges over data production and quality, as they are used to intervene in member states' practices. For one, these exchanges lead to a subtle alignment with WHO norms, not only of data production but also of immunization. Furthermore, in this practice of health diplomacy, the persistence of local idiosyncrasies of data collection is not framed as something to be resolved politically, in, for instance, an amendment to the international health regulations, but rather as a technical uncertainty that appear to be in the way of good data collection. The foregrounding of technicalities legitimizes those practices and forms a mean of health diplomacy, but it also amounts to a reduction of political interventions into national immunization systems and the way they are organized into seemingly technical ones. To sum up, The data practices and their infrastructures are not only the result of, but are also enabling health diplomacy. We find that infrastructures shape health diplomatic activities. They can mediate between local practices and global standards. They can also help to make diplomatic relations more durable. Health diplomacy does not only rest on carefully negotiated formal rules in the form of the international health regulations, for instance, which determine how data and information should be shared, but it also rests upon routines developed between different levels of governance. Foreign policy officials that hardly play a role in those everyday diplomatic practices that revolve around routine data production and sharing. It is rather epidemiologists, statisticians, or public health experts who act as diplomats and who, through seemingly technical exchanges of data, subtly contribute to an alignment of standards. Yet our case also suggests that in order to be successful, such data infrastructures need to be sensitive to local contexts, as much as this new generation of health diplomats need both technical and foreign policy skills to successfully collaborate. This shift in health diplomatic practices has important political implications as well. The fact that experts, rather than foreign policy actors, now act as data diplomats or diplomats means that their accountability is of course much more limited than those appointed by elected officials. And finally, the seemingly technical interventions should not mask the power dimensions of this form of health diplomacy, such as providing the WHO not only with expert authority, but also political authority. Thank you very much for your attention. I'm looking forward to discussing the case with you.